Welcome to the Direct Supply Virtual Clinical Leadership Conference. My name is Liz Jensen, and I'm the Clinical Director here at Direct Supply. We know that the workforce challenges, issues with post-pandemic, infection prevention and control, mergers, acquisitions, changing payment models, there's so much that as clinical leaders that we're facing in the industry today. Being able to stay current on the latest research and the impact on changing care models is important for clinical leaders. And I'm so pleased today to be able to bring you some great new information, great insights from some of the leading researchers in our field today. The topic for today is the impact of research on changing care models in senior care, a call to lead. As a reminder, this webinar is intended to provide general information, but not legal advice. Please also be aware that we are recording this webinar. Our panel today, we are joined by Dr. Tonya Roberts. Dr. Roberts is an associate professor and the Karen Frick Pridham Professor in Family-Centered Care at the University of Wisconsin-Madison School of Nursing. Our next panelist is Dr. Kathleen Unroe, Probari co-founder, CEO, and Chief Medical Officer. Dr. Unroe is an associate professor of medicine at Indiana University and a scientist at the Regenstrief Institute Center for Aging Research. And our third panelist today is Dr. Sheryl Zimmerman. She is the University Keenan Distinguished Professor in the Schools of Social Work and Public Health and a co-director for the Program on Aging, Disability, and Long-Term Care for the Cecil G. Sheps Center for Health Service at the University of North Carolina. We're so pleased to have this panel join us today. At this time, we're going to start our panel presentations, and first up is Dr. Sheryl Zimmerman. Hi, Sheryl, welcome. I'm going to turn it over to you.
Wonderful. Well, again, thank you, and everyone who's listening, thank you for being here. Liz, thank you for that very kind introduction. And as intimated, I'm going to be talking about research on care models in senior care with a focus on assisted living. Now, because assisted living is extremely variable, it's really important that we all have a common idea and a common understanding about what assisted living is and what assisted living isn't. So let's peel the onion back a little bit. What it is, the most simple definition is assisted living or care settings regulated by states to provide room and board to 4 or more residents, at least 2 meals a day, around-the-clock supervision, and help with personal care to a predominantly adult population. So what it's not licensed as a nursing home. It does not have to have nurses, and it's not federally regulated, meaning that there can be a lot of variability and much more diversity than in nursing homes. And there's a grounding philosophy of assisted living, and that's to provide personalized resident-centered care, accommodate preferences and meet needs, maximize dignity, respect, autonomy, privacy, independence, choice, safety, avoid the visual and procedural characteristics of an institutional setting, and encourage family and community involvement. These attributes are highly attractive, and many people who need supportive care don't necessarily need nursing home level care. So that drove more people to move into assisted living as opposed to nursing homes. People didn't want to be in nursing homes. And also, assisted living really had a good marketing advantage. So the growth has been phenomenal over the years. Between 1990 to 2002, what you see here, the number of assisted living beds increased 97%. The same time, the number of nursing home beds increased by only 7%. And the most recent statistics are that there's, as you see, more than 31,000 assisted living communities. These settings are not and do not want to be known as facilities, which sounds very institutional, but they prefer to be recognized as communities, housing more than 918,000 residents, which is more than half of all long-term care residents. When I provide this statistic, people say, well, there's actually more people in nursing homes than in assisted living. Well, that's true, but that includes short stay residents who are there for rehab. The majority of older adults who need supportive long-term care now reside in assisted living. And the problem is that these settings are highly variable. And actually, it's not a problem, that's a good thing, because if they're going to meet individual needs, we want them to be variable. But it creates a lot more challenges for the field. One is just what these places are called. They are regulated and they go by numerous different names. Here's just a handful of different types of names that are used to refer to what we generally think about assisted living. And the regulations have reflected some of this diversity. Across the states today, there are more than 182 different license classifications, 45 primary ones, 71 subtypes, 66 designations. But at the end of the day, if you think about making flavor combinations like ice cream flavors, there'd be 350 different flavors of ice cream that you can have, if you will, when it comes to assisted living. This variability is reflected in the exteriors of these. The top two photos shows how very variable the settings, the residences themselves are. These are all regulated as assisted living. And then, of course, also the internal spaces. The social and private spaces are very different across assisted living communities, as are the type of people who live there. So given all this tremendous growth that has happened and all the variability in assisted living, we raise the question, which many people are asking, is assisted living achieving its intent? All those wonderful attributes and aspirations. So we set out to answer that question and that overall focus by using expert opinion and drawing in literature to understand what is the current status of assisted living. In May 2021, we convened 25 diverse stakeholders in 2 half-day retreats, and their summative point was that they agreed, and vehemently so, that today's assisted living is not as intended in the past and must be reimagined for the future. I think that took many of us by surprise, because we all know that there's been areas that need improvement, but the fact that there was such consensus around this issue really was pretty eye-opening. And so specifically, what came out of these retreats was that, these being the initial constructs of assisted living, a philosophy, residential environment, and services that are supportive and responsive, all about focusing on quality of care, have really become mired down in 5 different tensions. These are what those tensions are. And in my upcoming slides, I'm going to tell you a little bit about each one of them and why they have become tensions for us to appreciate what assisted living, what we wanted it to be and what people were hoping it would be. The diverse stakeholders who weighed in on this entire topic are all listed there. Now, some of you may recognize some of those names, but what I really want to point out here is the diversity of the settings and the diversity of the viewpoints that were brought into this entire effort. We've got regulators represented, the National Association for Regulatory Administration. We've got the CARF is there in terms of accreditation, American Assisted Living Nurses Association. We've got provider organizations, Pioneer Network, Leading Age, Argentum, a lot of very, very broad perspectives who've all talked about the fact at the end of the day that we really need to be thinking about and be responsive to these 5 different tensions and literature and practice-based solutions to the tensions. And this is where the literature is going to come in. So what I'm going to do now essentially is provide a slide for each one of these types of tensions. First, when it comes to models, for this, there's actually about 4 tensions I'm going to be touching base on and potential solutions. One of the tensions is that there's a lot of different models, and basically they reflect what people have been developing and what states have been regulating. There's one type of model, institutional housing and services, and then service model. Those might be based on regulatory typologies. There's been some empirically based typologies, people doing research and saying, oh, look, you can separate privacy from service, etc. The problem is that we can create models, but leadership doesn't even know what those models are, nor do they necessarily agree with them. Communities don't market themselves that way, and therefore consumers aren't aware of what any of these differences are. So what's the potential solution? Well, consumer education, and a lot of websites provide information for consumers, but consumers don't know where to look. So we really need a more comprehensive and one-stop shop, if you will, for people to be able to understand what assisted living is, what the models are, and how they differ. Some years ago, the Agency for Healthcare Research and Quality put together a large panel and came up with some recommendations that could be used across the entire field for people to report what the assisted living is and what services it provides. We'd like to see that come back because there's a wonderful framework to do it. Second tension within this area is that models may not provide desired or necessary services. It could be in some cases that if you move into Sunny Acres Assisted Living, you're going to receive the services that Sunny Acres Assisted Living provides. That may not be what you need or what you want. So the solution here is to decouple services from housing. And this is already being done in some states. Connecticut does this. They license the services as opposed to the housing. And another example is bringing PACE models into assisted living. So that's certainly something that is being promoted. Another tension is that large-scale communities may focus more on the building than on the individuals, thinking that if you're in a place where there's more than 100 beds, it might be hard to personalize the services. So really having more of a focus on person-centeredness. But I do want to point out literature here says you can be person-centered even in large assisted living communities. And the last tension is that people have talked about assisted living being a social versus a medical model of care. And that initially started because people wanted to get away from this idea about being institutionalized, but it's created a real challenge because as resident acuity has gone up, people in nursing, in assisted living, look somewhat like people in nursing homes did a decade ago. People have said this may not be the right setting for them. And really, it's been important, and people who are proponents of assisted living have really been much more vocal, saying that even though these are not healthcare settings, does not mean that they intended to ignore healthcare. So we really need to put that dichotomy to rest. It's not a social versus a medical model. The second tension then is to talk about regulation and the status of regulation in assisted living. People largely agree that we need to have some type of regulation. It's a very complex field. There are people who are vulnerable, and there's public dollars, Medicaid dollars going into it. But the regulations are flawed. The regulatory arena is complicated, as I already showed, 350 different combinations. Regulations, whether they're nursing home or elsewhere, but same in assisted living, they set the floor rather than the ceiling. Some of them are outdated. They don't all reflect the assisted living philosophy of choice and safety, like some regulations like Florida. If a person has, I think, a stage 3 to 4 pressure ulcer, they need to move out of the community, even if they want to stay there and bring in services. And then, of course, there's regulations other than assisted living regulations, which could be dictating the care. So it's really quite a complex field. The recommendations here is to create and update regulations working in partnerships with assisted living stakeholders. This also, there's already models for this. Wisconsin is doing this, Ohio, Minnesota, Oregon, and New Jersey. There's good models for public-private partnerships so that we're focusing more on quality improvement as opposed to regulations. And the second one here similarly focuses about what the survey process doesn't accomplish. It's disdained because it's more punitive than it is quality improvement focused. So here the thought is to promote more professional approaches to quality improvement, such as accreditation, which is becoming more recognized within the field. The third area of tension has to do with financing, really financing and accessibility here. The challenge here is that investors and operators have focused on wealthier consumers. Median monthly cost, you see there, it's more than $4,000, almost as high as $7,000. Also, that the growth has outpaced other long-term care options in terms of inflation. Between 2004 and 2020, the cost increased 80%, while home care costs, for example, only increased 30%. So one potential solution here that has been successful in some areas is to offer federal tax incentives and public subsidies for owners and operators to better make assisted living accessible to the middle income individuals. The good news is almost half of communities are Medicaid certified, but a minority of residents use Medicaid. Access is limited, payments vary widely. Lowest is in North Dakota, highest in Pennsylvania. Of course, this is not specific with these challenges to assisted living, but here the recommendations are to remove waiting lists and coverage limits and really more fully include assisted living into states' long-term care rebalancing policies. The last tension in this area is, as I already talked about, various business models existing. And here, what we need to do is promote new models that link housing, primary care, care coordination, and financing, with a couple of examples being shown here. The next tension, nurse and direct care workforce. Well, we can't talk about anything happening in long-term care without talking about workforce. And in this context, one large component of the workforce is the same that's we're being experienced in nursing homes and elsewhere, is just an insufficient number of people available. And so we need to do some of the same fixes about inadequacies in pay and benefits, supervision, et cetera, all the different things that have been recommended to be able to improve and increase the number of qualified staff. The other two tensions I'm going to talk about, though, are more centric to assisted living. One is the staffing ratios are variable. They're often nonspecific and they're insufficient. I mean, quite literally, most of the regulation talks about having a sufficient number of staff, which can be quite arbitrary. And there's been some class action suits because of that, about there being insufficient number of staff. And although they do have a nurse on site, more than half have a nurse on site now, very different models for how those nurses are on site. And so we don't necessarily know whether it's a good thing or a bad thing because it depends on how it's being employed. So here, establishing acuity-based staffing recommendations, and I believe Oregon is currently studying this. And then last within here, again, more specific to assisted living, is the training is very variable, again, non-specific and insufficient. Only 40 states require any training at all for the direct care workers. And when they do, the hours can be as low as 1 hour. And only some states specify what they should actually be trained on. So here, of course, we want to make training be more rigorous and to promote competency-based training. Some states are now doing this with ARPA funding, is increasing training and talking more about competencies and really helping to professionalize the direct care workforce. The last tension is about the residents themselves. As is true in nursing homes, the majority of residents are white and non-Hispanic, but as our population is becoming more diverse, so too will the residents there. So we need to have training that's sensitive to cultural differences, and we need to be able to provide diverse services, and there's many models for how to provide more culturally sensitive services. But here, a very big concern has been that resident acuity has increased. Chronic illnesses have become a lot more common. A quarter of residents are hospitalized each year. Medical care is typically provided off-site, and cognitive and mental health care needs have become much more notable. You see statistics here: 42% dementia, 31% depression, 11% serious mental illness. Psychosocial care is insufficient, and segregated memory care is often ineffective. So here, what the recommendations are is to recognize that there are people with nursing home level of care needs who are living in assisted living. And what we need to do is to better provide, coordinate, or integrate the healthcare services that are actually needed for the people here. So I do want to drill on this as the last topic I want to talk about here, is just drill a little bit deeper about why we've got concerns regarding medical and mental health care and assisted living. And it is because of the rising acuity. Why is this a special concern? Well, it's what assisted living is. I said it's not really a social model of care, but it's certainly not been a healthcare setting. The variability I've talked about, some of these communities are as high as 499 beds. A lot of different variability. So we really need to understand and think about what might be cross-cutting. The people who live there, I did mention this in passing, but people say people in assisted living are like nursing home residents from a decade ago. And assisted living has become the primary provider of care to persons with dementia. So we really need to be sensitive to those needs. And who works there? There's limited medical and nursing provider presence. I already talked about that in terms of the workforce, as did I talk about the fact that there's limited direct care staffing and minimal training. So all of these have resulted in some concerns about care. We heard a lot, of course. I don't need to talk about infection prevention following what happened with COVID, but there have been many other and pre-existing concerns about medical and mental health care, and therefore the outcomes that the residents have had. Now, in response, though, I mean, care has been evolving. There has been an increase in nursing presence. As I said, more than half do have nurses. There is some integrated medical care. But the problem here is there's been no guidance regarding what structures and processes of care are actually optimal to be helping to inform nursing and medical care. And we need to do it thinking about the variability across all these different settings at the same time that assisted living does not become too medicalized, because there'd be concerns about, is it still person-centered? Do we need to worry about federal oversight? Is it going to become more costly and then therefore less accessible? The Washington Post picked up on this whole issue. And in December of 2022, I've got a little snippet of a summative point from this. And they said the nature of clientele in assisted living has changed dramatically, yet there's no widely accepted standards for addressing their physical and mental health needs. New report presents recommendations from experts, including patient advocates, assisted living providers, and medical, psychiatric, and dementia care experts, with hopes the recommendations will become a new standard of care. And indeed, that is what has come forth. This was a paper that was published in JAMA recently, based on expert Delphi consensus recommendations for medical and mental health care in assisted living. Delphi panels are a very common way to develop recommendations and consensus statements, as long as, and it's important that you get expertise and a broad swath of expertise from a lot of diverse and expert panelists. Here's an example of the people who were part of this particular panel. And what you see here, you see there's people who represent clinicians, provider groups, advocates, associations. There's assisted living nursing associations is here, AMDA, the Society of Post-Acute and Long-Term Care Medicine, Consumer Voice. So a very, very wide range of people who came together and reviewed basically 183 different potential areas of recommendations for medical and mental health care and assisted living. Myself and the other researchers on this project, we compiled 183 different potential areas to improve medical and mental health care and assisted living, based on literature, based on regulations, based on community guidelines. And for all 183 of them, we had these panelists rate the extent to which they were important to improve care, rated 1 to 9, and how feasible they were. For no communities, some communities, or all communities. What was the upshot of this? We thought, my goodness, it's going to be hard to get 19 diverse experts to be able to come to agreement on recommendations for medical and mental health care, but by gosh, they did. Of these 183 potential areas, they came up with 43 consensus recommendations in 5 different areas. And here you see I picked out the top ones from each of the different areas. So by way of example, on a score of 1 to 9, under the category of staff and staff training, whether there should be training for any staff on person-centered care, meaning all staff, that was scored above a 7, and specifically 8.89 out of a scale of 1 to 9. 100% of everyone agreed it was important. So using standard cut points for importance and also thinking about what's feasible, this project came up with 43 consensus recommendations, research-based recommendations to help drive medical and mental health care and assisted living, and also pointed out that many of these were not only assumed to be feasible, but there were data showing that many of them were already in place in the majority of assisted living communities. So they're important and they're pragmatic. So circling back to this slide I showed, the intent of all of these recommendations now is to generate widespread interest and knowledge and awareness of what these recommendations are, which is really why it's just such a wonderful opportunity to be able to present to you today, because now that you know that these recommendations exist, I hope that you will help promote them within your care settings. And also CEAL at UNC, which is being presented here as one of the organizations that's active within this space. CEAL at UNC and other organizations have launched the Be Well in AL Coalition, which is a coalition to promote medical and mental health care and assisted living. At the CEAL website, there's some information about that. I do hope you will all familiarize yourself that the paper is publicly available. So stay tuned. This is a great way to use research to promote better care and outcomes in assisted living by you and by your actions. Thank you very much.
Sheryl, wow, thank you so much. All right, next up, we have Dr. Kathleen Unroe. Hi, Kathleen.
Hi, Liz.
Thank you so much for joining us today.
Absolutely, absolutely.
I'm going to turn it over to you.
Well, excited to continue on with this panel. I'm going to talk a bit about Medicare Advantage in nursing homes, but really my interest in Medicare Advantage and other financing arrangements is opportunities to implement care models. So I will also talk a bit about, highlight some care models in particular. As Liz shared earlier, I am a geriatrician practicing in the nursing home setting and also the founder of Probari. So I'll talk about trends in Medicare Advantage, and then I-SNPs and D-SNPs is what I get most excited about when I'm thinking about the nursing home setting. And then again, hone in on some of these evidence-based care models that my team and I have been working on. So we've seen a lot of growth in Medicare Advantage over the last several years. So fewer than 1 in 5 Americans were enrolled in any Medicare Advantage plan back in 2007, and that has really increased over time, and it's at about 50%, about 48%. However, the penetration and distribution of Medicare Advantage is a little uneven across the country. So you can see this steady growth over time, but when you look geographically, you can really see how some states have a lot more Medicare Advantage penetration than other states. And when you look at the county level, you see this distribution, even more starkly, even within California, which is a state we often think of when we're thinking about Medicare Advantage. You can see there's some big differences across the state. The growth in Medicare Advantage is really led by a couple of companies, and so United Healthcare in particular has both a substantial share of enrollment and increase in enrollment. But between United and Humana, they have a lot of the Medicare Advantage business and products that are out there. And so some of the early research that was done in Medicare Advantage raised concerns that Medicare Advantage products were pulling maybe some of the healthier people out of fee-for-service Medicare. Some recent research has shown that there are a lot of people with chronic diseases who are being cared for under Medicare Advantage plans. And here is a little bit of data around specific conditions: heart failure, COPD, diabetes. So about a third and a little bit higher in Medicare Advantage plans compared to fee-for-service Medicare. And also, I think there were some early trends that were reported about beneficiaries with who had higher incomes being a part of Medicare Advantage plans versus fee-for-service. But here again, more recent data shows that shows the income distribution of people who are electing Medicare Advantage plans versus traditional fee-for-service. The growth in lower income in Medicare Advantage is somewhat driven by some of the special needs plans that I'm going to talk about. These SNPs, or special needs plan, are specific types of Medicare Advantage plans. There wasn't a lot of growth in this sector when Medicare was renewing them as a specific designation year by year, but about 5 years ago, they became permanent options for plans within Medicare Advantage. And so we have seen more growth in D-SNPs and I-SNPs over just the last few years, and new providers entering the market. So D-SNPs are for people who have Medicare and Medicaid, for dually eligible folks. And because it involves Medicaid, states actually approve what D-SNPs are permitted to operate within their state and can choose to exercise that discretion around what D-SNPs are in their state. And D-SNPs have traditionally cared for a lot of dually eligible people who live in home and community-based settings, although they may have members in a nursing home setting. And there are a couple plans who have a fair number of members in the nursing home setting. But I-SNPs are what I've been thinking about for quite a while with my focus on the nursing home setting, because I-SNPs, the I is institutional, are designed for people, long stay residents in nursing home settings. And I-SNPs, because of the clinically complex population that we care for in the nursing home setting, have a number of requirements around the resources the plan needs to including clinical care models. That is most often operationalized with nurse practitioners who are employed by the plan and will be in the facility to provide additional care on top of the primary care providers in the nursing home setting. So again, another map showing distribution of DSNPs by county. There's of course more complexity to these plans, and in particular this dark blue, which you don't see very many of them. That's a FIDE SNP, and so that's a fully integrated dual eligibles plan. So there's stronger integration between the Medicare and Medicaid financing streams. But what you also see here is these gray areas. So there's whole parts of the country, whole states where where DSNPs are not available. So depending on where you are based, you may see more or less of these insurance arrangements. So the reason that I have been interested, and I got interested in value-based payment arrangements and Medicare Advantage products, is because of my interest in care models. I think a lot about what is the optimal mix of services, resources, supports that we need to provide excellent clinical care in a nursing home setting. In a capitated environment such as an I-SNP, there's an incentive to care for people in-house, in the facility, and avoid hospital transfers. And as I said, care models, which often are operationalized as nurse practitioners in the building, are required in I-SNPs. And I believe that models such as I-SNPs create potential opportunity to implement proven care models. And I'd like to share a couple care models that my team based at Indiana University and I have been working on these last years. The first is this large project, Optimistic. This was a CMMI, Centers for Medicare and Medicaid Innovation Center, funded $30.3 million clinical, which was phase 1, and payment, which was phase 2 demonstration project. The goal was to reduce avoidable hospital transfers of long-stay nursing home residents. And in phase 1, we got to create and test a clinical collaborative care model. It was actually in phase 1, 19 partner facilities, and these were overall larger facilities. We embedded RNs in each of these buildings, and we also employed nurse practitioners to provide supportive care. And again, the focus was on long stay residents. In phase 2, we were able to retain 17 of the original 19, and we added on 23 additional facilities. So we were working with 40 facilities in phase 2. And phase 2 was about money. They wanted, within fee-for-service, to test new Medicare Part B codes to provide increased funds to care for sick residents in place. And we got to keep our clinical care model in phase 2 in those original facilities. So the original facilities got the care model, plus they were able to build the new Medicare Part B codes. The new facilities got some technical support from us, but the focus was that they had access to the new Medicare Part B codes. This is Indiana and the distribution of the facilities who participated in Optimistic. Central Indiana for phase 1, and we were able to cover more of the state in phase 2. But a little more specifically in terms of what this clinical care model looked like, the RNs embedded in the facility were tasked with being responsive to acute changes in conditions. They were interacting tools from the Interact program. They were also, they were very experienced RNs with many of whom had experience in the nursing home setting. And they coached and mentored the staff in the facilities. They also were a key support for the nurse practitioners. Nurse practitioners were only in a given facility a day a week, and having an RN embedded in the facility who could help direct them, help them use their time was very, very instrumental in helping them be effective. I'll talk a little bit more about the proactive advanced care planning piece of this. Again, they were gathering information to help with clinical reviews for the nurse practitioners, and they were integrated into quality improvement efforts in the building. The nurse practitioners were clinical. They were there to support with acute changes in conditions. They conducted detailed transition visits on anyone who did go out and then came back, and they supported the nurses in education efforts. We developed extensive tools and materials related to treating common conditions in the nursing facility, and best practices with transitions of care. So a whole library of materials we created as part of this project, working closely with our nursing facility partners. Palliative care was an important component in Optimistic, with a goal of reducing burdensome treatments, transitions, and appropriate referrals to palliative care and hospice services. We did a lot of training with our own nurses and nurse practitioners, and again, had a big focus on advanced care planning. Specifically, we helped with implementation of POST forms. Now, POST forms, some version of them, they have different names in different states, but largely look the same, are available in most states. It worked out timing-wise really well for us on the Optimistic project, because Indiana passed legislation making POST forms a legal option in July of 2013, right as we were getting up and going. So everyone started seeing these pink forms and wondering what the heck they were, and we could be the experts in supporting the 19 facilities in the project in a gold standard rollout of implementation of POST forms and how you integrate that into your care planning processes and then disseminate that throughout the companies participating in the project. All of our nurses and nurse practitioners, as well as several folks in our facilities, went through training in respecting choices, which is training to do standardized, high quality, advanced care planning facilitation. What we found is we gave these nurses a whole list of things that we wanted them to do. And one of them was advanced care planning. And we found that some of our nurses did a lot of advanced care planning and some did less. And so we wanted more standardization in terms of their approach to advanced care planning. So we shifted to a more systematic assignment-based approach. So the RNs in the project still were responsive to a big change in condition or transition or scheduled care plan meetings to initiate advanced care planning conversations. But in addition, they were given a list of names every month to approach either that resident or that resident surrogate as appropriate to schedule an advanced care planning conversation. And they would approach them up to 3 times, honoring any refusal. But if there was no response after 3 attempts, we considered that a passive refusal, sent them a letter offering them the opportunity in the future, documented that, and moved on. And in that systematic approach, we were able to reach a lot more residents and their families with this opportunity. And my colleague, Dr. Susan Hickman, and I carved out that part of Optimistic and are just completing a large pragmatic clinical trial to test this approach to systematic advanced care planning in facilities. But overall, we were just thrilled with the impact Optimistic and this big federal investment was able to have in our facilities in our state. Certainly, there was a lot of access to advanced care planning conversations, to transition visits, and other clinical encounters because of the program. But the Indiana site, Optimistic, did also demonstrate a reduction in all-cause hospitalizations of about 20% and nearly 30% reduction in avoidable hospitalizations. Switching gears, I wanted to also share about an ongoing clinical trial of a palliative care model in nursing homes that I am running alongside my colleague in the School of Social Work at the University of Maryland, Dr. John Cagle. Uplift, utilizing palliative leaders in facilities to transform care. Uplift is focused on training nursing home palliative care champions or leads. So existing nursing home staff receive additional training. And also, we are partnering nursing homes and external palliative care consultants, medical consultants, with an overall goal of improving quality of life and quality of care for nursing home residents with dementia. Now, I will say that I feel that palliative care should be offered broadly to the nursing home population. This particular grant was funded by the National Institute of Aging under the Dementia Research Funds, and that is our focus in this project, is the population with dementia. We created the Uplift intervention based on the evidence that is out there. And again, it includes internal capacity building, training staff in the facility as leads for the project. So a couple staff get a lot more training, and then offering all staff training on the basics of palliative care and the program. But in addition to this internal capacity building, we wanted to connect more external resources into facilities through external palliative care consultants integrating primary and specialty palliative care. This is a stepped wedge randomized controlled clinical trial. We are enrolling 16 facilities total. We have one left that we are recruiting in Maryland, but should be up and running soon. It hasn't marched out quite as cleanly due to our need to be responsive to facilities and the timing of when to start the trial. But we are on track to enroll over 640 residents in this trial. We are including residents with moderate to advanced dementia and who have been in the facility at least 30 days in the hopes of more of a long stay focus. Surrogate decision makers have the opportunity to opt the resident out. And we are collecting data from both staff and from family members regarding symptoms that the residents experience. But again, the in-house palliative care leads, their training centers around facilitating goals of care conversations and symptom management. But the biggest thing that we need them to do is to do systematic screening for palliative care needs among the resident population in order to identify who should get a specialty palliative care consult, and then to serve as a liaison to that external palliative care consultant. The consultant can come in, see the resident, talk with the family, and make recommendations, but we need that internal person who can work with the consultant to follow through on these recommendations, because ultimately the care is provided in the facility, so there needs to be strong communication. Really, I would argue in every clinical trial and program that we run in the nursing home setting, it may meet the technical definition of a pragmatic trial or not, but we have to have a pragmatic approach. We're working as researchers in partnership with clinical leaders in facilities. And in the Uplift trial, we identified core intervention elements that are part of the protocol that need to be delivered in this specific way. However, we tried to create flexibility in some of the elements as well to match the workflows, needs, and priorities of our facility partners. So to try to pull this together, there has certainly been continued growth in Medicare Advantage, and that's expected. Market penetration, though, is variable. So you will see a lot more or less of these financing models depending on where you are located. And there is also variation in the amount of care management or care models that these types of plans are required to include and may choose to include. But my hope is that increased growth on all kinds of value-based payment structures may provide opportunities to get some of these models of care that we are creating and testing on the academic side in collaboration with industry partners out into more sustainable, widespread implementation and dissemination. Thank you so much for the opportunity to speak at this conference, and I'd be happy to follow up if people have questions in the future.
Kathleen, thank you so much. All right, next up we have Dr. Tonya Roberts. I'm going to turn it over to you.
All right, thank you. Hi, and welcome everyone. I'm very excited to speak with you today. My name is Tonya, as Liz mentioned earlier, and I am at the School of Nursing. And just for a little bit of background, I wanted to let you know that I started working in nursing homes back in the mid-1990s and spent a number of years working as a CNA, a nurse supervisor, and assistant director of nursing. And since that time have transitioned into an academic role in these environments and have continued to sort of work on areas where I noted problems that were happening back then and continue to sort of plague us as time has gone on. And so you'll sort of see that as I go through the presentation. I also think that you're going to see a fair amount of overlap, interestingly enough, with what Sheryl had to say about assisted living. But my focus is really on the point of care, so the person-centered aspects of everyday on-the-ground care. And so I want to talk a little bit about innovations and research in person-centered care. So the research would show that there are various definitions of person-centered care, and from one study to another, or from one nursing home to another, what person-centered care means actually is different. However, across different studies and across different practices, these are some of the core consistent aspects or values of person-centeredness. So performing advanced care planning and goal settings that are conducted through shared responsibility and decision-making with residents and their loved ones or family members, engaging in mutual communication and developing trusting relationships between staff, the older person, and their relatives, providing care that is consistent with values of empathy, respect, dignity, autonomy, and human rights, the development of relationships, strong communication, shared decision-making, providing care that has a holistic focus and is individualized to meet the needs, values, and preferences of older adults and their family members, coordinating care. So if anyone needs care across settings, making sure that that care is coordinated, or care that is needed across different providers, and making sure that care really reflects what older adults value about their life and is consistent with their lifelong routines and patterns. What this means in that variation in the way we define person-centered care is that there are also variations in the way it's operationalized in practice. So person-centered care in some nursing homes may actually be focused on trying to improve dementia care, where models of care are focused on personhood, understanding persons' cues about what's important to them through observation, and making sure that we really attend to the needs of individuals who have dementia. In other places, we might be focused on preference-based living, which is trying to organize care around the daily routines and lifelong patterns of residents. Some places, person-centered care is really focused on making sure that care plans are individualized and holistic. In others, we're using person-centered care to integrate technology that helps individuals maintain connections and relationships or engage in personal growth. So for example, using computers so that individuals can continue to learn about things that are important to them. In other settings, the focus may be on trying to involve families, particularly in places where there's a large proportion of individuals that have dementia. So really incorporating families into the decision-making, both about the care of the residents and potentially about the way the nursing home organizes care and the systems that they provide or services that they provide. In other spaces and other nursing homes, there may be a significant focus on the physical environment and making the spaces look more home-like. So having residents bring in their blankets, comforters, decorations, mementos, and things that reflect what they've had or what they've loved for their entire life or what they might have had at home. In other places, a new emerging area of interest is making sure that we pay attention to equity and think about the needs of diverse residents, particularly those that might be from marginalized groups or the LGBTQ population. And then finally, making sure in some places that we are really making access available to anyone who needs it. And while I've separated each of these different areas on the slide, many places that are practicing person-centered care will do a combination of these different types of practices. So the research shows that person-centered care can really improve outcomes. Some of the research shows that at a baseline, there's no decline or worsening in outcomes, and in other studies have shown that there's improvement in outcomes. And these outcomes are at the resident, family, staff, and system level. So of course, we would expect that residents are impacted by the delivery of person-centered care, and it has been shown to improve quality of life, improve mood, reduce the symptoms associated with dementia, higher care satisfaction, and stable or even sometimes improved quality of care outcomes. So things like falls or other symptoms. For families, they feel when the resident is receiving person-centered care that they are more satisfied with the care that's delivered there. And now staff, as I think both Sheryl and Kathleen mentioned, staff is a major issue right now in long-term care across the board, and person-centered care models have been shown to be associated with reduced turnover of staff and higher job satisfaction. So that's a side benefit for some of the challenges that we're all facing in long-term care right now. And from a system standpoint, we see that there are occasionally reductions or an association with reductions in healthcare utilization, in other words, emergency room use or hospital stays, as well as fewer deficiencies at the nursing home. In addition to all of these benefits, we know that person-centered care is part of mandatory practices guided by regulations. And so I just share exact language from the operations manual that you can see here, and I'm sure everyone watching this is very familiar with this. But regulations suggest that we need to focus on the resident as their locus of control and support them in making choices and having control over their daily lives. We also need to integrate the resident and their representative into the development of a person-centered care plan. Some of the most significant innovations in person-centered care have been happening over approximately the last 20 years. And so I believe many of you are probably familiar with all of these, but I'm going to briefly mention them in case anything is new to you. But culture change is a label used to reflect a model of care that's really transforming all of the systems that we use in long-term care to meet the needs of residents. So small house or neighborhood models, the Eden model and the greenhouse model are some examples of how the hierarchical institutional medical model of nursing homes have been sort of flipped upside down. And so the goal is to create spaces that reflect more of a home-like environment. They're on a small scale. Workers are cross-trained to do jobs beyond just their task-based focused work that they would typically do in the nursing home. And the routines and daily rhythms of the home or the neighborhood are really driven by residents. Many of these require some significant transformation to the physical environment of a nursing home, either through remodeling, renovations, or new builds. So these are things that are invested in by just a few organizations. In addition to that, in places where those sort of physical environment changes haven't taken place, there have been other changes like choosing buffet or menu-based dining systems rather than the traditional style where we put the food on trays and we send it out at a specific time of day and everyone gets the same meal. This offers some control over what residents select to eat and when they eat it, especially in the buffet sort of style. There's been some work to create spa rooms rather than the sort of stark shower room that's typical in a nursing home environment, and really offering more flexibility in the sleep and wake times to align with more natural routines that residents have typically followed their entire life. And as I mentioned earlier, the idea of cross-training workers so that they do more than potentially just the direct care, but additional tasks on small scale so that it seems as though, my example always is that you're almost being cared for by a daughter who does a little bit of everything. And so if you're not familiar with these types of models or these types of innovations, the Pioneer Network and the Greenhouse Project is a place that I would highly recommend that you check out. The Pioneer Network holds an annual conference, and people who attend that conference are often able to learn about some of the latest and greatest innovations in person-centered care. So within the context of trying to improve person-centered care, there are many different challenges going on in the long-term care background. And I won't go into too many of these, as I know that Sheryl covered several of these already in her presentation. But in particular, staffing shortages and the upcoming potential staffing mandates and staffing minimums have created a tension where we're really focusing on basically trying to cover the holes in staffing, and there's little opportunity to really think about innovating at the care level or the point of care. We just need to get some staff into the building and enough staff to meet the basic needs. So that's an ongoing challenge. In addition to that, there are now a number of changing and evolving regulations in this post-COVID world. And so there's this need to continually be aware of what those regulations are, how they're changing, and how that's going to actually impact practice on the ground level. There's been some rapid changes in MDS after a very long period where there were no changes for many, many years, and now it's changing more regularly. Reimbursement rates and the payment models are changing, and those reimbursement rates in the background are typically not at a level that's high enough to support additional resources needed for innovation. In addition, we have very old buildings in most cases, and it can be really challenging to make changes, renovations, or remodel those in ways that can effectively support that more home-like setting. And then the focus of QAPI on care that comes from our regulations now is really, encouraging us to think about how do we improve a care practice we're already doing. It doesn't necessarily help us think about how do we innovate and completely change what we're doing, and how do we actually understand if the practices we've been doing all along should be drastically or significantly altered rather than just improved. So given the challenging context, unfortunately, we don't see that person-centered care is consistently provided across nursing homes. Despite the regulation, despite the sort of humanistic value that we all have, those challenges in the background are really limiting the ability to fully adopt a number of different person-centered care models. And you would see in the National Academies, which was commissioned recently to look at the needs of nursing homes for improvement, that they came up with 7 different potential recommendations to improve nursing home care. And I have those listed here. I'm just going to talk about the first one. It's to deliver comprehensive, person-centered, equitable care. So again, despite the 20 years of innovation, despite the regulations, we are still seeing today that we need to focus on this and continue to work toward improvements and innovation. If you haven't seen this report, I would definitely encourage you to look at it. It is 600 or 700 pages, but there are a number of different summaries that you can take a look at. So the Moving Forward Coalition, again, if you're not familiar with that, is a massive effort that grew out of the National Academies report and is funded by the John E. Hartford Foundation to really try to tackle all of those 7 different recommendations with simultaneous plans for addressing those interrelated complex factors. I'm a part of this coalition, and I am on the committee that's working on improving care planning and trying to think about ways that we can make private rooms more common in nursing homes. And so I have the website here for this as well. I would encourage everyone to take a look at that, and you can sign up for announcements. And I think you could continue to watch the work that comes out of this group, especially if you have an interest in trying to revise or improve person-centered care models in your own organization. And then finally, I just want to say a few things specifically about my work at the Center for Aging Research and Education at UW-Madison and the direction that it's going. We're starting a lot of these different projects that really are focused on trying to optimize what we do every day in nursing homes. So rather than thinking about completely changing the model or doing things that require more funding or require more staff, my work really looks at what are we doing now and how can we actually optimize it in ways that make it more efficient, yet maintain its person-centeredness. So I'm doing some research on care planning and care conferences and really looking at ways that we can develop clinical decision support systems for person-centered care so that we're best able to align care to preferences. And briefly, I'll just mention that care planning and care conferences, well, care conferences in particular, are hardly ever researched. There is almost no literature on care conferences, and yet they consume a great amount of time and effort in our everyday nursing home care. So my research has started to do work like observing care conferences. What actually happens there? Are they achieving the intent? Are we achieving the goals that we believe they should be meeting? And where are some opportunities for us to make change? So for example, we've found that these are fairly unstructured. We don't really have a plan going into a care conference for what to talk about and how we're going to approach them. And the care plan itself almost never comes up in the discussion. And rather what we see is that they're used as an opportunity for the interdisciplinary team to give status updates about the resident, tell the family about certain goals that they think may need to be in place, and seeking sort of endorsement or the, okay, that sounds good. It is not really focused on trying to collaboratively work with residents and families in ways that impact the care plan specifically. So we're working on some very low tech approaches, paper and pen sorts of things that will help us work with residents and families so that they know what a care conference is, what to expect will be discussed, identify what they want to talk about in advance, and then run the care conference with their agenda in mind, covering all of their needs and bringing the information that they request and that they want to discuss ahead of time to the care conference. And what we're finding is that we're very easily able to completely shift a care conference to achieve the intent to engage residents and families in setting goals by doing very low tech things. And in terms of the clinical decision support, I think that all I want to say about that right now is that one of the things that we commonly do in nursing homes is arrange our direct care workers and our nurses and other staff to be assigned based on either the census, so overall how many residents do we have and how many does that allow us to have on a shift, and then we assign them to work based on what rooms are clustered together. And what I want to do in the future with this work is think about how to actually staff and organize assignments around resident needs and preferences rather than their room or the census, which is typical. So that work will also be sort of innovative in that we're thinking about our current systems and looking for efficiencies that could be improved on without actually requiring more resources or more staff. And then finally, I've been working with a computer science student recently who is thinking about the use of robotics for supporting staff in meeting some of the functional needs of residents. Her work is focused now on assisted living, but I think this is another place where there's potential for innovation in the future. And if you want to see any other resources that the Center for Aging Research and Education has, I have the website here for you to take a look at that as well. To wrap up, I just want to mention a few places that you all could potentially make change or act right now if you haven't been doing person-centered care. One of the key things that you can do is think about ways that you can consistently assign the same staff to residents. And so even if you don't have a lot of staff or you have unstable staff, the staff that you do, as much as possible, if you can assign them to the same residents, they get to know more about the resident, their preferences, their idiosyncrasies, and they can actually provide care that aligns with those preferences. Think about places in your everyday work that you sort of take for granted, or the sort of sacred cows. What do we do all the time that could potentially be optimized or reorganized in a way that could make things more efficient while still being person-centered? And then I would definitely encourage thinking about ways to potentially audit, monitor, take a look at in more depth that care conference, care planning process, and the implementation of care that matches that care plan. And think about any ways that you can sort of automate that process or make that more efficient as well. And so one example might be changing your electronic health record in a way that could automate collecting data during the assessment process, like the MDS, that will get preference information and could be used to guide those everyday routines and the care that aligns with those routines on the ground. So I'm going to stop there. And if you have any questions, please don't hesitate to reach out. Thank you.
Tonya, thank you so much. At this point, we're going to bring up our other two panelists. All right. So I have a couple questions for the group here. And actually, Tonya, in the kind of the last slide that you shared, some very, kind of practical insights that you had to offer made me think about how overall, I think the compelling research and the evidence that's driving these changing care models, and how we really heard today ideas that are impacting the system at a lot of different levels, from the, the different levels of, changes that are being inspired by changing payer systems, the consensus among experts in making recommendations for offering medical and mental health care in assisted living. Sheryl, can you talk a little bit about any advice that you might have specific to some of the attendees that are on here today that may include health and wellness directors, directors of nursing? We've got, regional nurses, educators, corporate level nurses. As you're thinking about the system as a whole, do you have any thoughts on, where nurses the nurses, depending on the roles that they're in, can really start to work at maybe impacting the implementation of some of these consensus recommendations?
Wow. Great question. I don't know if there's a great answer. As with most things, we really want to start with obviously low-hanging fruit. And in this case, so many of the recommendations, as I said, they're practical. If one goes to the paper, it's very easy. I mean, like having advanced care planning discussions, kind of circling back to some of these other presentations we just heard, just having discussions, that's one of the recommendations. A recommendation such as if a resident goes out for medical and mental health care to come back to the community with some written document about what transpired during that and what the recommendations were, the care practice recommendations. So in the context of thinking about the low-hanging fruit, I think it's really just a matter of having all of the clinicians, all the leaders who are part of this conference, understanding what those recommendations are, bringing those to people's awareness. And on occasion, sure, maybe there would be a tool. Maybe in the last example I gave, maybe having a standardized written form about here's something that people could use to write down what the recommendations are, what the treatment plan is after someone went out for a medical care visit. And part of the Be Well in AL Coalition is to develop a toolkit of those types of things. So I think my simple answer is, as with many things, a lot of what we're doing in this field, and I think my colleagues, Kathleen and Tonya, a lot of this isn't rocket science. It's just being aware, and to the extent someone can take the time and be purposeful, I think there's a lot of things that can be done that can improve care and outcomes, and everybody wins. The workers win, the residents win, the family members win, the organizations win.
I could not agree with you more, Sheryl. Thank you. I think I've seen that in my own work, as well with the organizations that we work with. Kathleen, I wanted to turn to you just for a bit and ask you about, really in my role here at Direct Supply, I work with engineers and technology developers to understand and interpret where gaps exist in systems and senior care settings, where tech innovations can impact workflow efficiencies, staff job satisfaction, as Sheryl and Tonya both talked about. Where are you seeing opportunities, do you think, for technology to help support the teams in the efforts that they're undertaking that might be inspired by these changing payer structures and systems?
So I think there are some exciting, technological advancements, some technologies we've seen in other care settings that may translate well to our setting. I tend to evaluate them with a skeptical eye at first. The care we provide in nursing facilities is absolutely very human touch driven and human resources. I think actually I might not have talked about staffing, but it's hard to talk about innovation and quality in nursing homes without talking about staffing. So technologies that truly are evaluated with an eye of, can we make a staff person's job at the nursing facility better, easier, equip them with tools that are actually useful to provide care? Can we offload them in any way that helps them provide more care at the bedside? So are there tasks tasks that nurses are doing or CNAs are doing where they're away from the bedside, where they're behind a computer trying to sort through and synthesize data? Are there technologies and tools that help pull data together and serve it up for clinical staff? That's where I think there are some opportunities. But I think we just have to always be asking those questions about how it layers in, how it truly supports or disrupts nursing workflow to see if it is a truly valuable innovation. Programs that provide too much data or data that it's not timed well, I think can be a disruptor. But technologies that improve lines of communication between the doctors or medical consultants and nursing staff and hopefully families as well, I think there are some exciting opportunities there. I know that's pretty general, Liz, so I do think there's some exciting tech opportunities out there, but I'm very cautious as I think about how they're applied and implemented. There's all kinds of things that sound very cool, but then we have to play it out to the real life, what this feels like and looks like in practice, and we have to test them. And so that's, again, I'd say, I think there's such opportunity to partner with industry, partner with researchers to test some of these technologies. One opportunity are through SBIRs, or small business grants from the NIH, and I've participated in a few of those type of grants where we are doing exactly that, testing technologies in the nursing home setting with a real eye to both how is this technology used, how is it implemented, and how do nursing staff, residents, and families feel about this technology.
I couldn't agree more. I think, I get to see kind of up front and close and personal just the challenges with some of, these initial innovations, and, how do we actually help continue to tie them to the actual needs and, feel confident that they're delivering on the promise that they potentially could have as well. So thank you, Kathleen. I appreciate that insight. And as you were talking, Kathleen, it made me think about, Tonya, how your focus and your work on the clinical decision support tools, as well as person-centered care. I'm wondering if you can talk a little bit about how the residents themselves are experiencing maybe the shifts and changes that you're seeing, maybe through their eyes. Could you talk a little bit about how all of this change is kind of impacting that from the residents' viewpoint?
Yeah, sure. So I think there's a couple of things happening in terms of the resident perception of person-centered care and the implementation of really significant person-centered care models. When our resident is already living in a traditional nursing home and has either moved to a nursing home that has a more person-centered model, like a greenhouse, for example, they're able to really perceive a change. They're able to perceive a difference because they experienced what that traditional setting was like before. I think when a resident starts off in a facility or a community or a nursing home where that's already common everyday practice, they're not really able to perceive this in a way that is a operationalization or a reflection of this being different, right? They don't have that past or prior experience. And I would say that, in a lot of places, there's still the same sort of concerns from the resident perspective. And I spend a lot of hours in my research talking directly to residents and family members. And, there's still the challenge of getting the call light answered quickly, not being able to take a bath more than 2 times a week. So some of these things are persistent issues that we just need, as Sheryl said, to sort of step back and look at purposefully and intentionally to say, okay, are there some places where we are being a little too systematic and not person-centered? And can we take, any kind of footstep toward making this more person-centered? So I think, the resident perception is a little bit challenging, but at a broad level, the research does show that if you compare quality of life for folks who are staying in a traditional nursing home with one that's person-centered, the quality of life is definitely higher in those that are person-centered.
Tonya, thank you. I think that this focus on the person-centered care is the perfect place for us to kind of wrap up our conversation for today. Everything that we've talked about today, all of the care models and the changes in these care models, all really ultimately, hopefully, will come down to that, right? That we're able to significantly impact the quality of life for the individuals we're caring for today and those who we'll care for in the future. It's really the imperative for all of us to be keeping that in mind through all of the different lenses, through the payer change lens, through the technology lens, through the research lens, all of these different areas and how they're really focusing on that. So I think that's a unique place that nurses as clinicians can really have an impact and on the operations in the organization and really bring that voice forward on behalf of the resident themselves as well. So thank you to our panelists today, all three of you. I'm so grateful that you took the time to come and share your research with us and just to get to spend some time with all of you. I'm just so impressed by the work that you're doing and really grateful that you were able to come and share that with our group here today. So thank you so much. This concludes today's presentation. Direct Supply sponsors webinars on a wide range of topics and offers complimentary contact hours for administrators, nurses, and other interprofessional staff. Visit our website to learn more. Thank you all for joining us for our virtual clinical leadership conference.